Well, we've had the chance to, can you hear me? Yes. To hear three very interesting, provocative, successful programs. Do we have questions? No, I have one or two right off the bat while we're waiting for people to come to the microphones. It appears in the nursing literature that nursing has been speaking about a moral crisis for at least 2 decades. Three. I can understand the timing even better now that it's 3 decades. But physician, it's just creeping into the physician lexicon now. Why do you think that is? Are we responding to different moral crises or different factors, or are the stresses that are reaching the physicians now historic stresses that nurses have been dealing with for many, many years? Or is it a combination?
Well, I wish I knew the complete answer to that. I can only speculate. I think one of the issues is that nurses have been at the point of care always. And when you are in a situation where you're carrying out the decisions of other people, it puts you in a very in the middle place. And it seems to me that physicians for a very long time were operating in a large sense of autonomy in terms of their practice. And I think as practice has become more constrained for physicians, their situation is similar to the constraints that nurses feel in terms of being able to do what they think is right and not being able to do it, which is why they feel distressed. Right. So I feel like there is this sort of accumulation of constraint, which is what causes the moral adversity. And I do think that the foundation of that is related to our inability to be who we really are and to be able to enact the values that are central to our identity as nurses and doctors and other clinicians. And it's that gap that accumulates, and we know that when we can't relieve that, there's a residue.
Right. Okay. Well, I think, we have some people at the microphones. Why don't we start on the right?
I'm Wald. I'm from Boston Children's Hospital. Hi, Boston. And also Brown Medical School. I've been doing some traveling nationally and giving some talks on resilience and well-being, and one of the concerns that I've been hearing from medical students relates to what is required, and this is something Dr. Rabow was talking about. I wondered if you could address this in the sense of thinking more around a smorgasbord of resilient strategies work, which is what I've been working on, and think about that in terms of the sensitivity of the learners and what we are actually requiring. So that's one question, and the other was just around something that Cynda had mentioned in relation to the measures that we're using. I have some real concerns about maybe we can think more qualitatively, and that's not as respected perhaps in the literature, but to think more qualitatively along with the quantitative methods. So I just wanted to ask those.
Thank you very much for your question. This question of elective versus required is a really key one, obviously, as we're thinking about what we're going to do to other people, what we're going to require of them, what we're going to make them do, how we're going to change culture. Every time I've had this discussion, I keep going back to the recognition that there's all sorts of things that we require of students that they may not want to elect to do. Biochemistry may be an example for many of us in the room. So to a certain extent, we do have to figure out what it means that we are even considering whether or not to make resiliency skill building, to make well-being promotion, to make burnout prevention elective. It says something about our hidden curriculum to think that these important and vital elements of being a professional healer could even be conceived of as being elective. That being said, I think your point is really well taken, that there's lots of ways that different people learn. There's lots of ways that different people are ready or not to learn various things. So that we can customize, that we can really create a whole panel of different experiences that work for different people at different times is going to be, I think, really, really important. And of course, that means that we need to know our learners better. We need to know how they learn. We need to know when they're ready for what, because one size is clearly not going to fit all.
And resources for faculty development to help with well-being of faculty who can then do that kind of customizing.
Absolutely. I think one of the things that we've experienced in the healer's art is that students are acutely aware to the walking the walk, talking the talk issue. And so when they hear things that come out of the mouths of their faculty that they know the faculty don't believe or don't practice, it doesn't lead to their learning. And so having faculty who are actually living resiliency, who are actually living well-being, who are actually living a practice that's consistent with ongoing education, ongoing learning, and ongoing commitment to values is really, really key for our learners.
Just say one thing on Hetty's point about measurement. What we measure is what we move. And so it's back to the point of what do we actually want to see as the result of our work. Whether it's measuring burnout as evidence of the suffering of the clinicians, are there other ways to detect the changes in terms of work engagement, in terms of resilience? And I do think that we have to have more than quantitative measures, although we all seem very seduced by them. I think there's a richness that we lose by not capturing some other ways, like innovation, diffusion of innovation, and how we can begin to see change in our culture.
On the left, please.
Dave Rothenberger of the University of Minnesota. I appreciated the discussion and the whole day. Actually, it's been a wonderful, I think, experience to participate in this. Question related to the Brigham program. Have you been able to move some of the things you're doing directly into sort of immediate interventions? Have you done, I'm thinking specifically about how we've worked in surgery to change our traditional M&M where some poor resident stood up and took abuse for a while, and that was, we all walked out of the room feeling, well, that was great, we took care of that problem. And we've now moved to better, I think, root cause analyses and a little more thoughtful process, but we still sort of don't have, in my mind, the part that you've added. And I'm wondering if you've been able to do that. And I was brought up short when we had a recent named lecturer who came and talked about the first living donor death in the United States that happened a number of years ago. And he talked about the crisis in his life that created, and that no one sort of knew about most of this. He's since is ultimately recovered and is now head of a major program in the United States. But one of our own faculty members stood up and said, you know, what other profession does what we do in surgery, or in medicine? An untoward event happens, a patient dies, and if you're the surgeon, what are you supposed to do? Well, you're supposed to go dictate the note, talk to the family, and do the list, the next patient. What other profession would ask somebody to do that?
Police, every day.
Police ask them every day? I thought they were put on suspension, really. I thought they had an administrative leave and they were given support. Well, that's interesting. But I still, the question.
Yeah, no, it's a great question, and all the work that we're doing is very integrated, by the way, in our hospital with safety and quality. I sit on the Executive Patient Safety Committee. And to your point, we just actually published a study in the Joint Commission Journal for Quality and Safety where we looked at all of the processes across the entire hospital for event analysis, M&M, QI, educational conferences, and we asked about what happens during those with an eye to looking at a couple of variables, including were systems issues, learned from, would people talk about their errors? Did they actually say that they did them? And specifically, do they talk to the patient about them? Because we have a disclosure coaching program that we wanted this data to inform. And then was there any discussion of or reference to peer support? And so what I can tell you is that the actual moment of having an event analysis obviously is focused very much on the learning, knowing what we know now, what can we do next time, rather now than it used to be when we trained, which was who's the moron, okay, don't do it again, right? And so we know that's really key, and that's a big culture change, going to adjust culture from shame and blame. And within that, but what I would say is that the actual peer support, the kind of peer support that we do, it should be a little bit in the M&Ms, but it's not really the focus. Where it needs to happen is separate from that, and that's why we have these proactive reach out. There's an adverse event, you get a call. And I could tell you offline what we do in peer support, because it's more than just saying, hey buddy, how's it going? There's a lot of trying to get somebody else's coping strategies in place, and lots of other things that we don't do well instinctively as healers. We want to fix the problem. So when I do training for peer supporters, I try to teach them, stop trying to fix your colleague. You can't fix their pain, but you can witness it with them and you can help them. You get the picture. So yes and no to your answer. I think the more we move to a culture that is not shame and blame, and that has to happen during an event analysis, and then also it focuses on, okay, what can we do for the patient? In parallel to that, how can we support you as the clinician to be there for the patient and family? That's the disclosure part of it. So it's all of a package, but not necessarily at the same time.
I think we're going to have time for just two more questions, the two at the mic. Yes, please.
Mr. Cesare, I'm from Bassett Healthcare, which is a rural healthcare network in central New York. And I appreciate the comments made about the peer support, and appreciate all that would go into both to help support our colleagues and also to help promote collegiality and resiliency in the network, in the institution itself. But I was wondering, from the collaborative perspective, if someone could comment about work to change, if you would, the legal aspects of discoverability, and because that's certainly something that's going to promote that culture of silence.
Yeah, I would like to answer that very directly. So that was obviously of concern in constructing this program, and we collaborated with and we have CRICO here. They were incredibly supportive, our insurers for the Harvard teaching hospitals, also the defense attorneys, our risk managers, leaders, et cetera. And what we decided was that even though technically these peer support interventions are discoverable, that the way we do them, that the risk of causing harm to the clinician if there's a lawsuit is so minimal. And the risk of, our big argument was, we know the risk of not doing it. And the risk of not doing it is huge. And so it's a risk benefit, just like any procedure is. And we have never, and I can say this is true of all the places I've helped start these programs in the country, in other countries. I guess they have different laws, of course, but there's never been a problem with this. There's not, because there's no notes are taken, and it really is a focus on the person's story of what happened, rather than, my God, I can't believe you did that. What were you thinking? There's no judgment. It's really hearing from their point of view what happened, and then going on to how they're going to cope with it, including how they're going to be part of a system solution or how they've learned from this. So, very fair question, but it just hasn't been a problem.
And our last question?
Actually, we've gotten permission from Jake to get two from the web also.
Okay.
Okay.
Yes.
First, I'm really struck by I've heard it in your presentation as well as some earlier presentations around the lack of funding on this. And at one level, I find it a little bit amusing because, I'm coming in from the outside. I have a lot of experience in a lot of different industries and large systems. And I'll tell you that, you know, the conundrums that I'm finding healthcare, I'm going to change the word providers, professionals encounter are not that different than a lot of other industries. The big difference is that you have immediate outcome. You're right there. You're at the bedside. It's an immediate impact, and unlike places like education and manufacturing and governance, where there's a little bit of a delayed effect, there's no wonder that the stress is and the distress is so high. But with regard to the funding, I guess I'm curious if you have seen, or if you think that the relevance of healthcare is learning to be healthy, and that's what I hear anyway. And you know, maybe there was a time when healthcare professionals were healthy, and that a number of operational and organizational things have changed that. My guess is that our culture is not healthy. Healthcare works with an unhealthy culture and works to repair, and healthcare is learning to be healthy, and so you're in a very unique position. I guess I just want to offer some words of encouragement, especially for those of you who seek funding for these kinds of things, because to bring in healthcare in your industry, you're probably one of the most unique places to be able to be effective quickly, and that can have a very strong ripple effect into other industries like education and governance and some of the other places where I think our cultural unwellness is also there, but not as evident. So thank you.
I appreciate the comments. Two questions from the web.
We have, this is for the whole panel, highly collaborative team intelligence and getting results done together seems to be a leadership style that drives physician engagement and restoration. This leadership style is not very common. How do you suggest we pivot, and how should we lead health systems to tap physician partnership input and collaboration as a burnout countermeasure, and correlation, where do we find these leaders?
I'm not a member of the panel.
You know, I'll just take a stab at that. Thank you, whoever asked that question. I mean, I would point you to one of Tate Shanafeld's studies that looked at the outcomes of respectful leadership and how that positively affected satisfaction and engagement of the, I think, physicians that they studied, and it also was correlated negatively with burnout. And this is in part how I made the case to our leadership that this commitment on their part to resource this center. Obviously, I'm not a profit center in the professionalism and peer support, but that it was both the morally right thing to do and would be connected to lots of outcomes that they all care about, in particular, patient care, recruitment, retention, morale, productivity. I mean, this was back where I don't know that we had all that much evidence for what I was saying to be true, but there was enough to make it feel real to people. So I think that particularly the question about leadership is getting the people who are hiring the leaders to see that they've got to recruit for people who have those attributes of collaborative leadership and are respectful and also skilled at emotional self-regulation and conflict resolution, all those things that really we just didn't know were important in leadership. We really picked people who had certain kinds of skills. So I think one is the recruitment, but I think also faculty development, someone else mentioned. I mean, we really can train leaders. I spend most of my time, if you will, as far as doing faculty development, in training leaders how to give difficult feedback. Because our inability, and positive feedback as well, to our anthropologists, that You know, you have to learn to be specific about, hey, when you said that yesterday at the meeting, that was incredibly helpful. Here's why I thought it was wonderful. And develop that habit, and the same thing if it doesn't go well to say that. So I guess the short answer is, it's recruitment, it's the people hiring the leaders, valuing those skills, and then helping develop those skills when the leaders start in your institution.
I totally agree with that, and we just add from the Healers Art experience, our research shows that the Healers Art faculty, the faculty facilitators who sit and listen and keep time basically, get more out of the course than even the students do. So I think one of the things that we're learning is that we need to stay connected to the enthusiasm, to the idealism of our students, because by the time you're, you know, a dean, a program director, you may have been gone a long time since the kind of idealism and direct connection to your values. So we have something that we can get from our students that will help keep us and our institutions, I think, centered.
So I agree totally, and I think sometimes it's easy for us to point the finger at the leadership gap, which is real. And at the same time, our leaders are people, and they are experiencing this, you know, their own version of burnout and adversity that they're dealing with. So it seems that there's another piece of this, is how do we help them to connect to their basic humanity and their values, because the message we've said over and over here today is you can't give what you don't have yourself. And so we need to think about how do we cultivate the climate and the conditions for leaders to bring their best forward. And as you know, Joe said, to select people who actually have that commitment to the kinds of qualities that we want to see infused in our organizations.
Our final one, Tim?
Last one is just circles us back to some of the things we've already talked about. Most physicians go into the field to help others. What specifically can you experts think or give advice to that can be done from a technological standpoint to improve workload and increase resilience? The EMR seems to have made practice of medicine a 24-hour-a-day duty. Can the EMR be reformed?
We're probably not the right people.
Wrong group.
Yes, it can.
Do you have another?
Absolutely. Tomorrow.
I would add one thing, which I think is relevant here to the EMR, which is ritual. Ritual is a practice that draws, points at the truth and something that's meaningful, but doesn't necessarily take a lot of time. So I think that there are people all across the country and the world who have developed their own personal rituals for maintaining presence, and that's essentially a mindfulness practice that can happen nearly instantaneously. If every time you washed your hands before seeing a patient or before touching your EMR, which is probably a good idea, certainly after, you thought about how you were doing the work that you were meant to do, that you were seeing in the sufferer, the fates of God, whatever it is that works for you, ritual, which can be integrated into everyday life, including a busy EMR, I think can be important.
I don't know if I agree with the idea that, you know, that this is going to be a technical solution. I think this is an adaptive problem, not a technical one. I think we could harness technology to do it. And maybe just getting back to Alan's point is, you know, if we give people time to both be with the patients, but also to be in community, whether that's a reflection moment where people can mourn the loss of, you know, there were pediatric ICU, we had 4, you know, babies die. I mean, you know, to not be able to come together as community, even if it's just weekly or monthly, to honor the feelings that we have and reconnect with each other. And it doesn't have to, you know, it doesn't have to take a week's retreat. I think that's another ritual, but getting back to connection with community.
Well, I think it's always uplifting to me to finish meetings like this with solutions, and I think our group today has brought forth solutions for some of the aspects of the challenges we face, and hopefully this collaborative will continue to provide solutions, not only at an individual level, but at a national level. So we appreciate your kicking this off with us. Thank you.